Hello and welcome to another video of RRR, and today we are going to talk on the topics of post-operative care, focusing more on bladder and ureteric injury, vascular injury, nerve injury, and we'll do some questions as well together. Okay, so first of all, this is the urinary tract injuries in laparoscopic gynecological surgery, prevention, recognition, and management. This is the TOG article. So, a few important questions from this article. The most common visceral injury related to laparoscopic pelvic surgery is, the answer is bladder injury. The incidence of bladder injury varies between 0.02 to 8.3%. The most common surgical step leading to injury is the dissection of the bladder from the cervix. The most common site of injury is just midline above the interureteric bar. The risk factors, as you can see here in the box, the risk factors associated with urinary tract injuries are presence of endometriosis, cancer, adhesions, severe genital organ prolapse, obesity, and pregnancy. So these are some of the important high yield facts from this article. Okay, so this we are talking about post-operative recognition. How will we recognize the injuries post-op? It can be a delayed recovery. The signs and symptoms can include pain, hematuria, leakage of urine per vaginum, or oliguria. Also, there can be chemical peritonitis when the urine is leaking into the peritoneum and can lead to peritonitis. Sometimes it has been seen that the tenderness may be absent. Any thermal injury because of energy devices sometimes can present 10 to 14 days later as a fistula or uroperitoneum. So we have to be careful to look even after even 10 to 14 days after surgery. The common investigations that we do includes serum creatinine level, which can be very high. An can include a CT scan with contrast. The presence of uroperitoneum, or we can see sometimes the location of the injury with that. Other investigations can include retrograde cystography and cystoscopy. When there is a fistula, then we can do a filling test with methylene blue. So we can demonstrate the leak of the dye into the vagina. And MRI can also be employed as one of the investigations for diagnosing injury. Now, the steps for the repair. The bladder can be repaired in 1 or 2 layers. So these are the basic principles of repair which we should follow in case of any urinary tract injuries while operating. It should be sutured in 1 to 2 layers using 2-0 or 3-0 absorbable sutures, polygalactin or Vicryl. It should be a non-locking repair, and the suture should be placed 0.5 to 1 centimeters apart and also laterally to the edge of the incision. And that gives them a good watertight closure. Injuries involving the bladder should be dealt carefully. Stents should be used so that we preserve the ureters. Ureteral stents must be inserted. Patency of urethra and ureters should be confirmed after a repair. As I said before, watertight and leakage from suture line should be tested with either a dye and checking the leak. Bladder catheter should be inserted for at least 2 weeks. Again, there are different school of thoughts about the duration of the catheter, but a long-term catheter is needed to help the repair process. Before we remove the catheter, a retrograde cystography is employed to check the repair and healing. Now, how can we prevent urinary tract injuries? If we are expecting there to be distorted anatomy, we should do further investigations to ascertain the anatomy before we start the case, like an MRI with or without IVU should be done. Intraoperatively, ureteric peristalsis should be tracked and the course should be followed. It's a good idea to dissect and expose the ureter before we begin with the actual procedure. Mobilization of the ureter using a medial to lateral blunt sweeping technique can be used. And we can use ureteric stents so that we can see the ureters intraoperatively and make sure we are far away from them. And the post-op recognition, failure to recover as anticipated, flank pain, flank tenderness, oliguria, anuria, hydronephrosis, uroperitoneum, urinomas, abscess, which will be detected on imaging. And again, it can present later, 10 to 14 days later. However, intraoperative identification can be done by cystoscopy, where you actually see visualization of the orifices and urine jets, which you can see from the cystoscope coming inside the bladder. Presence of blood or air suggests injuries, IV administration of a dye, and then waiting for the dye to see as a urine jet through the ureters is also one of a good test to confirm the viability of the ureters. Ureteroscopy can also be done. It can clearly tell you the exact level of injury. Retrograde, antegrade, and intravenous ureteropylography can also confirm or refute the diagnosis and also can pinpoint at the location of injury for the repair. Okay, so now we are looking at the 1 second. Yeah, so surgical principles of repair. Adequate and careful debridement is necessary. Adequate and careful dissection to avoid devascularization or avoid damaging to the blood vessel supply to the ureter is needed. The closure should be watertight, tension-free, and spatulated or fish mouth. We should use absorbable and intermittent suture of adequate the thickness. Avoid too many sutures, but avoid too less sutures. Use of a stent or a catheter is necessary to help with the repair. Omental flap can be used to help with the repair, to cover the repair site as it increases the blood supply to the area. And again, with the laparoscopy, the recovery is much faster as compared to a laparotomy. So, if the surgeon is capable of doing a repair laparoscopically, that should be preferred. And then the types of repair that we do. If the injury is at the upper one third of the ureter, we can directly do end-to-end anastomosis or de-anastomosis of the ureter. It is known as ureterostomy. If the injury is in the middle third of the ureter, either ureterostomy or transureterostomy may be done, which is joining the ureter to the adjacent ureter or the other ureter and making an anastomosis there. If the injury is in the lower one thirds, then we can do a ureteroneocystostomy, which is reimplantation of the ureter, or we can use a Swas hitch or a Bowery flap, which we will see in the next coming slides. If there is a minor crush injury or a needle injury, it can be managed conservatively if the vascular supply has not been damaged and there is good peristalsis and there is no urinary leak, then we can continue a conservative management with the drainage system. If there is an obstruction, then stenting is a good option for the healing. And if there is a thermal injury, which we have recognized, and we want to prevent the fibrosis and stenosis, then again, we can use stents. As you can see in this slide, these are the values with a cesarean section. There is a chance of 0.1% injury to bladder with a cesarean section and 0.4 ureter injury. And these are the times where the injury can happen and the treatment for the same. This is during a C-section. The rates are during a C-section. And again, we are seeing here the types of repair. You can see a transureterostomy on the leftmost side. And then this is the Swas hitch. What it involves is fixing the bladder to the iliopsoas muscle tendon. That helps with the repair, gives a little bit of a length to the ureter without causing excessive tension. Also, this is Bowery's flap. It also creates an oblique flap with the dome of bladder, and it is closed vertically. This again gives length to the ureter and prevents causing excess tension on the repair and helps with the healing, with the vascular supply as well. Now we come to bowel injury. Bowel injury is less common than bladder injury, but nonetheless, it's a very important to know the recognition and diagnosis and management of bowel injury with any gynecological or obstetric procedures. So if there is a intra-op recognition, the best thing that we can do is primary repair. If it is a small, then we can just close it in layers. Or if it is a bigger injury or there are multiple injuries, then we need to do the resection of bowel segment and the repair. And I would be we should always involve the general surgeons and the experts to help us with the repair. If there is a thermal injury, it can present 48 to 72 hours later as a bowel perforation and tissue necrosis. So we have to be careful post-op and we have to keep a close watch on the patient post-op as well. It can also lead to sepsis. So post-op intra-abdominal sepsis is also one of the presentations of bowel injury. The imagings that we can do include CT scan, in which we will show air fluid levels, distended loop of bowels, evidence of abscess, inflammation, and this can be helpful in diagnosing post-operatively a bowel injury. Management should include aggressive management of the peritonitis, supportive care, and of course repair of the injury, which can include colostomy, resection of a bowel segment, and repair. Now we'll talk a little bit about nerve injuries associated with gynecological surgeries, common nerves injured during gynecological procedures and their presentations. A little bit about the pathophysiology, neuropraxia, which is the nerve compression, axontemesis, which is axon damage. The recovery takes longer, and neuroentemesis, which is poor prognosis if we don't do a restorative surgery. Chronic nerve-related pain is seen about 7% of women with a fan and steel incision that is due to entrapment of ilioinguinal or iliohypogastric nerves. Again, this shows common nerves injured, what are their sensory functions, the motor functions, and clinical presentations. This is quite a high yield table and it will help you solve a lot of questions for any exams. As you can see, hyperflexion, abduction, and external rotation of the hip results in kinking of the femoral nerve under the inguinal ligament, which can be a result of the placement of the patient during surgery. So it's very important to ensure proper presentation and proper support to the legs, especially when we put patients in lithotomy in gynecological surgeries. Sometimes the positioning of the arms of the patient or the neck of the patient can also lead to trauma to the brachial plexus. And again, we can see the nerves damaged, the sensory motor functions, and the clinical presentation all in this table. Okay, now here's a little question for presentation and the nerve injured. Um, Inability to climb stairs is femoral nerve. Foot drop is peroneal nerve. Problems with thigh adduction is obturator nerve. Neuralgia paresthetica is lateral cutaneous nerve of thigh, only sensory nerve. Perineal pain is pudendal nerve. Pain over femoral triangle is genitofemoral nerve. Kivas deformity of foot is tibial nerve. Erb's palsy C5, C6, claw hand C8, T1, and wrist drop is radial nerve. So if you remember these clinical presentations, you will be able to solve most of the questions that are associated with nerve injury. Now we'll do some questions. The first question, these are the options for the first EMQ. Okay. And the question is, post laparoscopy, a suspected ureteric kink with an intermittent pain and normal imaging. What can be the next step? So there is a kink, but the imaging is normal. So we can see if we go back to the options. These are the options. So the answer would be E, which is placement of ureteric stent and postoperative monitoring. Because out of these options, ureteric stent is a very helpful method to treat a ureteric kink. If stents are inserted without resistance and under direct vision, we ensure that they do not exit the injury and can also rule out obstruction. So it can be a therapeutic for a kink. This has been taken from the TOG article, which we've already discussed. The next question. A minor ureteric serosal tear is observed during surgery without any urinary leak. What is the best course? And the options are here. So again, this is a serosal tear. So ureteric stenting and monitoring will be the best option because it will help any superficial injuries or minor injuries. Stenting alone itself can serve as a modality for treatment. Next question. Bladder injury is suspected intraoperatively but is not confirmed. What are the immediate tests that help confirm the diagnosis? Can we go back to the options? And the answer is an intraoperative cystoscopy, directly visualization of the lesion, and assess the bladder integrity. We can also use dyes to see the ureteric jet or the urine jet, which can be seen in the cystoscopy to confirm the patency of the ureters. So again, a bladder injury that will communicate with the spate of Retzius might go unnoticed, as opposed to the commonly expected laparoscopic injury that communicates with the intraperitoneal cavity. Sometimes the damage can be in the space of Retzius or it retroperitoneally. So intraoperative cystoscopy is advised if we are suspecting any kind of injuries. Now, next question. In a complex case, the distal ureter is completely transected at the surgery. What is the definitive repair? Here are the options. So the answer will be ureterostomy, that is ureteric reimplantation with a psoas hitch or a Bowry's flap, because it's happening in the lower third of the ureter. Next question. These are the options, and the question is, which abdominal entry approach is safer for minimizing vascular injury? So we are talking about the entry approach for preventing a vascular injury. And these are the options for the EMQ. The answer is an open entry instead of a varus needle. Varus needle is a blind entry method. Sometimes it can damage major blood vessels. So an open technique where you can directly see where you are putting your probe, where you're putting your ports, is helpful to prevent any vascular injuries. Next question. In which scenario should you proceed to laparoscopy rather than a conservative management amongst the following options? The answer is a suspected perforation during an activated loop resection. This has been taken from the TOG article, the ruptured uterus, perforated uterus. I'm sorry, and that is a very good article that deals with the injury to the uterus during hysteroscopic procedures and how to manage them. So a perforation that has been identified after a using of an activated loop, resection loop, or a laser fiber, or during a termination of pregnancy, or removal of products of conception, laparoscopy should be done, because to make sure the extent of the injury and to the damage to in any other intraperitoneal structures. And it should be done by a senior person or a skilled person. So the next question, the options are this, and the question is, on day 3 after a cesarean section, a suspected ACPO develops, increasing pain and focal peritonism in the right iliac fossa. Cecal diameter on CT is 12.8 and CRP is rising. Lactate is borderline high. She has not yet received neostigmine. Which statement is most accurate? The options are these. Now, this relates with a postoperative complication, more commonly after a cesarean section. The answer is an urgent surgical or colorectal review is required due to the high perforation risk because the colonic diameter is more than 12 centimeters and there are signs of localized tenderness and ischemia. Cecal diameter more than 12 centimeter or localized tenderness are red flags for chances of perforation, and urgent escalation is needed to prevent further damage. Following a radical hysterectomy and pelvic lymphadenectomy, a patient has growing pain, weakness of hip adduction, and sensory loss of medial thigh. Knee extension and ankle movements are intact. What is the best diagnosis? So it is most commonly due to an obturator nerve neuropathy because it runs along the pelvic side wall and it is vulnerable during lymphadenectomy or paravaginal dissection. Adductor weakness and medial thigh sensory loss are the classical features. Early recognition can lead to early repair, um, and if it is transected, um, or we can also employ conservative measures. After prolonged lithotomy with legs compressed against the stirrup post, patient has foot drop and sensory loss over the dorsum of the foot and lateral leg. Plantar flexion relatively preserved. What is the diagnosis? As we can see, foot drop can point towards a peroneal nerve neuropathy, and it can lead to all the symptoms as discussed above. Now, next question. During a laparoscopic surgery, a 2 centimeter laceration to the bladder is noted. No further pathology is present. What is the optimal management? These are the options. The answer is immediate repair and a two-layer closure, as we have discussed before. Now, let's move on to some SBAs. A patient with no allergies is undergoing open mammectomy. Which preoperative skin preparation is recommended to minimize surgical site infection risk? The answer is alcohol-based chlorhexidine should be used. It is superior to povidone iodine in reducing the surgical site infection in a clean contaminated surgery unless there is a contraindication. The next question is which clinical feature helps differentiate obturator nerve injury from lumbosacral plexus involvement? And the answer is adductor weakness only. Obturator neuropathy presents with hip adduction weakness and medial thigh sensory loss. In contrast, lumbosacral plexus involvement can lead to multiple motor groups damage and a broader loss of power and sensation. Next question. During a retroperitoneal lymph node dissection, the surgeon inadvertently injures a nerve on the anterior surface of the source, leading to numbness of mons pubis and anterior upper thigh. Which nerve is this? A nerve lying on the anterior surface of psoas major muscle is the genitofemoral nerve. Genitofemoral nerve, L1, L2 is the trunk, emerges from the lumbar plexus and runs on the anterior psoas major muscle. Genital branch supplies the mons pubis and labia major, and femoral branch supplies the upper anterior thigh sensation. Next question. Day 2 after a laparoscopic myomectomy, the patient develops lower abdominal pain, ileus, and increasing drain output. that is straw colored, and serum creatinine is normal. Which is the most useful immediate step? We go on to doing the drain fluid creatinine as compared to serum, which gives us helpful in diagnosing a bladder leak. Next question. We are counseling for a laparoscopic surgery for a benign disease. Which of the statements is most accurate? The ureteric injuries are 3 times more common than bladder injuries. Bladder injury is more common than ureteric injury in benign laparoscopic gynecology surgeries. Lower urinary tract injuries overall more than 3%. Most lower urinary tract injuries are recognized only post-op. Vaginal hysterectomy has the highest laparoscopic injury rate. The best answer is bladder injury is more common than the ureteric injury. We saw the incidence in the initial slides. And so systemic data on laparoscopic procedures show lower urinary tract injury is 0.3%, bladder 0.24%, and ureter 0.08%. So bladder injury is about 3 times more common than ureteric injury. During TLH, you are unsure whether the left ureteric peristalsis During TLH, you are unsure whether the left ureteric peristalsis and course are intact after stapling the uterine vessels. No obvious transection is seen. What is the next best option? The best option is to do a cystoscopy to check the ureteric jets and stenting. Next question. A patient with two previous midline laparotomies need a pelvic adhesiolysis by laparoscopy. There is a concern about the vascular injury during entry. The next best step is. We discussed this in another question. Palmer's point, Verey's insertion, or an open Hassan's technique can be used. And if there is a previous midline incision, then it's better to do a Palmer's point entry. The next question, sudden massive bleeding occurs from a trocar site vessel during laparoscopy. What is the first action? The best option is to apply direct pressure on with a suction or a sponge stick and ask for help so that we can get the theater team ready as well as get the necessary expertise to do the repair. But in the meantime, to decrease the blood loss, the best thing to do is apply pressure. Despite pressure, a major bleeding continues along a growing broad ligament hematoma. What will be the next step? So if there is a broad ligament hematoma and if it is not being able to manage laparoscopically, there is a need to convert to laparotomy promptly without wasting time because the patient's continuously bleeding into the broad ligament and can become hemodynamic compromised at any point. Last question. You plan to insert a 5 mm port in the lower quadrant lateral to the rectus. To avoid the deep inferior epigastric vessels, the safest site is. So it is said to be more than 5 cm lateral to the midline. Deep inferior epigastric vessels run above 4 to 5 cm lateral to the midline. So if the port is placed laterally to the 5 cm from the midline, there is a less chance of injury to the deep epigastric vessels. Although we still use the illumination and direct visualization before putting the secondary ports. That's all about this topic. Thank you so much for your patient listening and all the best with your preparation. Thank you.